I'm Ehsan Malek, Director of Translational Research in Multiple Myeloma in Roswell Park Comprehensive Cancer Center in Buffalo, New York. I have privilege to be forefront of CAR T-cell research in multiple myeloma. We had an extraordinary finding that was presented in ASCO 2025 in Chicago, and that is the follow-up, 5 years follow-up of patients with the BCMA CAR T-cell therapy, and is around that 1/3 of patients after 5 years they stay MRD negative. MRD negative means minimal residual disease negative, implying that essentially with most sensitive technology that we have in the market, we could not find multiple myeloma in patients' bone marrow. It's very hopeful. Essentially the best benchmark, therapeutic benchmark that we met in history of multiple myeloma. It's the first time that we are using cure term very cautiously. Obviously we have to follow this 1/3 of patients to see if they're going to relapse or not, but after 5 years they stay MRD negative is very hopeful results. When I talk about CAR T-cell with patients, I usually use analogy of the automobile industry. In 1908 we had a first Ford T model that came to market, essentially made it possible for every citizen to buy a car and transport with the car. So it showed what is the potential to entire world. It's the same with CAR T-cell. First generation CAR T-cell that we have in the market right now, they are just introduction, just the telling the patients what is possible for achieving very deep remission in multiple myeloma. We have different avenues. As using the same analogy, we obviously we want to modify engine, how we can make engine stronger, how we can make engine last longer. One of the things in the Roswell we are very passionate about, that's making armor CAR T-cell, that how this CAR T-cell they can survive in harder climate condition. For example, in immune suppressive environment of the myeloma, how they can survive longer, how we can add more targets, make the engine more efficient, and with GPRC5 and other targets, we make one CAR T that can target more molecules on myeloma cells, have a hassle-free access for more citizens. For this automobile analogy, how we can produce CAR T-cells much faster. We have homegrown CAR T-cells that academic centers they can use, or allogenic source of CAR T-cell that we can have manufactured one time for all patients. We are one of the best centers to offer this modality to our patients with multiple myeloma. From physician standpoint that you treat multiple myeloma, always we ask this question: should we put patient on bispecific, a class of molecules that it needs continuous therapy, is a type of immune therapy versus CAR T-cell? And this is a very valid question from patient standpoint as well as treating physician standpoint. And the answer to that is obviously bispecific will be used at some point in patients' myeloma journey. However, based on International Myeloma Working Group instruction, CAR T-cell should be offered before bispecific, and the reason for that is bispecific, there are a class of therapeutic options that if they have a long exposure, they can lead to T-cell energy or T-cell exhaustion, and making CAR T-cell out of that exhausted T-cells, it doesn't result to best efficacy from CAR T-cell. So always is advisable to offer CAR T-cell before moving to bispecific as a therapeutic agent. If you're a patient with multiple myeloma at first relapse or later, we offer this therapy just on real time. You can just call us, make an appointment, we can see you less than a week, and we can initiate CAR T-cell BCMA for you.